Hello, greetings to everyone joining us. On behalf of the World Society of Surgical Oncology, it's a pleasure to welcome you to the first ever webinar, to our first ever webinar. We are an international society dedicated to advancing excellence, equity, and education with a strong commitment to global collaboration and evidence-based care. Today's webinar is centered on the theme universal access to surgical oncology treatment, challenges and paths to the global equity. Surgical oncology is a cornerstone of cancer care, and its quality directly influences survival, functional outcomes, and quality of life. However, access to safe, timely, and high-quality cancer surgery is not guaranteed everywhere. Rather than presenting a global overview here, this section was intentionally designed to give voice to regional perspective. Representatives from different parts of the world will share their realities, challenges, and solutions, allowing us to learn directly from diverse contexts and experiences. With that, we will move forward to the regional presentations and begin this important discussion. From Africa, we have Dr. Newton Rosa. From Asia, India, we have Dr. Chandra Mohan. From North America, we have Dr. Anna Gleisner. From Central America, we have Dr. Sergio Torres. From South America, we have Dr. Mariano Jimenez. From Oceania, we have Dr. Ailton Sepulveda. Thank you.
Rodrigo, and my directors. My name is Alexandre Ferreira Oliveira. I am general surgeon and an oncology surgeon. During this term, I am serving as president of the World Society of Surgical Oncology. It is a great pleasure that we begin the first webinar of the World Society of Surgical Oncology, which will address a topic that was one of the main reasons for the creation of our society: universal access to surgical oncology treatment, challenges and pathways to global equity. In the globalized world in which we live, information can circulate very quickly. However, the means and the resources necessary to implement knowledge are not always accessible. Create strategies bringing people together and giving a voice to all surgery who treat cancer around the world is the DNA of this society, founded on November 6, 2025. I'd like to thank our current board members and founding partners for joining us in this initiative, which will help patients around the world who suffer from these diseases, which unfortunately is expected to become the leading cause of death worldwide after 2029. Newton. Next.
Good evening, everyone. My name is Nilton Kaitanda Rosa. I'm Angolan, surgical oncologist, and today I'm going to talk about the surgical oncology in Africa, the struggle for infrastructure, human resources, and overcoming sociocultural barriers. It is a pleasure to be here. I would like to thank the organization for this invitation. So, no disclosure related to this presentation. And I will start to talk about the African continent. That is a very young continent. The life expectancy in Africa is 64 years old, and with a population of 1.4 billion people. And cancer is a problem. We expect 1 million new cases and approximately 2 million in the next 5 years. So we need to deliver safe, affordable, and timely cancer surgery. Surgery is one of the major pillars in cancer care, and approximately 80% of patients will undergo some type of procedure along the oncologic trajectory. It can be preventive, diagnostic, and curative, supportive, palliative, and reconstructive. And around 60 million people die from conditions that require surgical care each year, most of them, of course, in lower income and middle income countries. Surgical oncology in Africa, well, we have a restricted number of surgeons, results in the major barrier to cancer care. Access to safe, optimal surgical services for cancer is poor. Lack of awareness. We usually treat patients is in Africa is commonly used the alternative medicine and what leads us to poor treatments of outcomes. So when we talk about delays in cancer care, we talk about access delay, diagnosis delay, and treatment delays. When we talk about access delay, of course, and diagnosis delay, we usually talk about teaching because we need institutional readiness, clinical training, research, and of course leadership. It's difficult establish a cancer unit in low-income countries because the cancer unit must be capable of managing patients according to contemporary standards of good practice. What is quite difficult because the access to resources. Patients receiving surgery in Africa are younger than the global average with a lower risk profile and yet are twice likely to die. The effects of surgery training is a prognostic factor for cancer surgery success. And in Africa, we talk about institutional readiness. So when they see none, do none, we can teach none. Is a known barrier to provision of safe surgical treatment in Africa. Low hospital procedure volumes and international studies are dominated by activity in high-income countries. And of course, data in African countries is very poor as well. So cancer outcomes in Africa are shaped less by tumor biology and more by access, timing, and system design. I would like to thank you. See you soon. Bye-bye.
So, hello everyone. At the outset, let me thank the WSSO for conducting such a good meeting. And I also thank WSO for inviting me to talk about this various issues of surgical oncology in Southeast Asia. Surgical oncology as a specialty is growing in Southeast Asia. As a part of the growth, it is facing certain issues which is affecting the standard cancer care being delivered to population at large. Let me go one by one. Which are the challenges? The first challenge is the surging burden of cancers. 70% of the cancers patients in low middle income countries present with very advanced cancers because of lack of screening facilities. There is a beautiful article which is published in Lancet recently by the Indian author Dr. Pramesh, it expects 17 million new patients requiring 24 million cancer operations, and in some patients you have to operate multiple times. So 45 million cancer operations may be done in these 17 million patients. And over 10 million patients in low and middle income countries will be in need of cancer surgery. Looking at the figure, the world population share of low middle income countries are nearly 48%, but you look at the workforce which is available is hardly 20 to 30%. And again, when you look at the density of specialists per 1 lakh population, the low middle income countries are at 10 below 20, which is the minimum number which is required. But if you look at the developed countries, you can see more than 50 specialists are present per million population. And 80% cancer patients require surgery, and only 25% will have access to timely and affordable cancer care in such countries. And the workforce shortage is going to increase further in 2040, where we are expecting an increased number of cancers, and 383% gap in cancer surgeons and 550% gaps in anesthesia procedures, according to the Lancet article. And financial toxicity is also widespread. The out-of-pocket expenditure and catastrophic expenditure occurs in as high as 70% of the population. And research facilities are suboptimal. With reference to India, which are the motivating factors, which are the positive factors for surgical oncology? First of all, the manpower training. Every year, 200 to 250 surgeons are formally trained in surgical oncology all across India. And Indian Association of Surgical Oncology is further promoting manpower training. It also popularizes cancer surgery. It has a lot of international collaborations and exchange programs, which you all know. And it also licenses with the government and government organizations for advancing cancer surgery. And another scheme, which has been running in India for the last 5 or 10 years, is the Ayushman Bharat scheme, where 40% of the population gets cancer care free of cost. It's a very ambitious project. It being widely practiced all across Indian states. Even though a lot of things has to improve, this is a great relief for cancer victims. And in global surgery, what are things to be done? We have to integrate surgery into national control plans. We have to build context-appropriate surgical capacity, prioritizing high-burden cancers, optimizing training, and ensuring basic requirement and safe anesthesia. We have to strengthen multidisciplinary teams. We have to implement safety and quality systems in surgical checklists. And expand our surgical oncology research with equitable funding, mentorship, and local priority-driven drive studies. Reform education training through standardized curricula, fellowships, and global partnership. Invest in sustainable financing models to reduce the out-of-pocket cost and integrate surgery into the universal healthcare. Scale surgical workforce through the task sharing, accelerated training, and retention strategies. Promote mental health and prevent burnout of the workforce. Build system robust to pandemics, conflict, and disasters. And the action to be done include various stakeholders like government, policymakers, hospital administrations, surgical leaders, societies, research and funders, and international organizations, WHO, to provide technical and financial support for infrastructure, training, and crisis resilient systems. So what is the role of WSSO? It can make policies and suggest countries to implement policies, if it comes from a larger body, it has to be listened carefully by the governments, promote exchange programs, use digital platforms for training, promote advocacy and campaigns by members, promote research activities, and learn from each other. Thank you very much for the patient listening. Hope we can make significant changes in the world for cancer patients. Thank you very much.
Good morning, and thank you for the opportunity to speak here today. My name is Anna Gleisner, and I'm a surgical oncologist at the University of Colorado. I was asked to speak on persistent disparities in North American surgical oncology, race, income, and health coverage. This is a broad topic for 8 minutes, but I'm going to do my best. We can't talk about disparities without talking about social determinants of health. These conditions in which people are born, grow, live, work, and age are the major drivers of health disparities across populations. Things like employment status, income level, poverty, health literacy, internet access, and very importantly here in the United States, structural racism are some of the examples of social determinants of health. Even though a lot of the studies that I'm going to present that have traditionally focused on race and insurance status, the environment in which people live have profound effects on both access and quality of care. When it comes to race, we know that Black patients are less likely to receive cancer-directed surgery for gastrointestinal cancers. In this study, for example, after controlling for insurance status and other social determinants of health, Black patients were less likely to receive surgery for several types of cancer, most notably esophageal cancer, in which the absolute difference was 21%. And even when Black patients undergo surgery, they experience worse cancer-specific survival than white patients. These differences can at least be partially explained by worse outcomes after surgical oncology operations across multiple dimensions. After controlling for socioeconomic factors, Black patients undergoing major cancer surgery in this study had higher rates of post-operative complications, higher in-hospital mortality, higher transfusion rates, and prolonged hospital stay compared to white patients. Where patients live also significantly influence their access and quality of care. Rural populations have higher rates of late-stage diagnosis. In this study, for example, people residing in non-metropolitan counties had the lowest proportions of localized stage cancers and the highest proportions of distant stage cancers for lung, breast, and cervical cancers compared to large metropolitan area residents. Rural residents in isolated areas had higher odds of being diagnosed with late-stage colorectal cancer, lung cancer, and prostate cancer compared to urban residents. But without a doubt, health coverage is the major driver of access to care in the United States. In this study, near a third of the patients without health coverage had to delay or did not receive needed medical care because of cost. When it comes to cancer screening, 80% of the uninsured patients were not up to date with colorectal cancer screening, and 70% of these patients were not being screened for breast cancer. Once the patients turn 65 years old and are then eligible to government-based insurance or Medicare, delays of care become rare and compliance to screening increases significantly. Uninsured status remains the strongest driver of late-stage cancer presentation and reduced access to surgery. In this study, compared to privately insured patients, uninsured patients were significantly more likely to be diagnosed with late-stage disease for both lung cancer and colorectal cancer. They also had lower odds of receiving cancer surgery. And here is how race and insurance status are interconnected. While 7.8% of white patients are uninsured, 13.7% of Black patients, 18.7% of American Indian and Alaskan Native patients, and 28.7% of Hispanic patients are uninsured. These populations are also much more likely to have less education, to live in poverty, and less likely to own a house. Because healthcare coverage is one of the most important drivers of disparities, it is not surprising that Medicaid expansion under the Affordable Care Act has been associated with earlier stages at diagnosis and improved survival outcomes for different cancers. In this study from 2020, also addressing the effects of Medicaid expansion, the authors found that after Medicaid expansion, there was a significant decrease in uninsured patients diagnosed with cancer in the states that expanded Medicaid. They also noticed that expansion of Medicaid increased access to cancer surgery, with a marked effect in the populations of lower socioeconomic status. Even though a lack of healthcare coverage is a major driver of disparities, the Canadian experience has shown us that universal healthcare alone isn't sufficient to achieve health equity. The Indigenous population of Canada, for example, has been shown to have less access to cancer screening, diagnosis at more advanced stages, and worse survival outcomes. When looking for possible barriers to care, a review of multiple studies found that racism, discrimination, lack of culturally safe care, geographic isolation, and historical trauma from colonization were the most important factors for this population. Black Canadians also experienced notable disparities in cancer care and outcomes. For example, in this study, using a large national Canadian database, it was shown that Black women are diagnosed with stage 3 or 4 breast cancer about a third of the time, and that was significantly higher proportion compared to other populations. Finally, geographic barriers significantly impact cancer outcomes in Canada's vast territory. Patients that live in rural areas are less likely to get screened for cancer and have lower rates of cancer resectability, especially when it involves a high-risk operation, which is at least in part due to a large distance between their homes and the nearest treatment center. In conclusion, disparities in surgical oncology are pervasive and persistent in North America across race, ethnicity, socioeconomic status, and geography, and affects every stage from diagnosis through survival. Lack or limited health coverage is one of the most important drivers of disparities, but as we know from the Canadian experience, disparities persist despite universal health care. This is because disparities are rooted in social determinants of health, limited access to education, economic opportunity, and high quality of care. Thank you for your time and attention.
Hello, my name is Sergio Lopez Torres. I am surgical oncology from Managua, Nicaragua. I work with hepatobiliary cancer disease. It's an honor to me to share with you in this important webinar of the World Society of Surgical Oncology. I will talk about access and resource management challenge for surgical oncology in Central America and the Caribbean. Why this region matters? The population in this region is about 90 million of people. The cancer incidence and mortality increasing steadily. The cancer burden growing faster than system capacity. The common is late stage presentation. The surgery is required in more than 70% of cancer patients. surgical oncology access is a global equity issue. Access to surgical oncology care is highly centralized cancer service. We have a lot of geographic barriers, like rural areas, like transportation, and island nation. We have big forests, so it's difficult to go from the rural areas to urban areas where it's concentrated the cancer service, the surgery often delayed, oncology windows. Access is different. We have a long waiting times and delayed referrals. Human resource constraint. We have a shortage of training surgical oncologists. We have a limited specialization like hepatobiliary, colorectal, breast cancer. We had to go another country like Mexico, United States, or Europe to internate in this specialization. It's a lack of a structural fellowship in this region. In some cases, the general surgeon managing complex cancer case, the burnout, uneven distribution of expertise. This is a comparison between the training and fellowship in the different countries in Central America. Panama and Costa Rica has a better training center, more than Guatemala, Honduras, and Nicaragua. Infrastructure and technology gaps, limited operating room, limited beds, intensive care unit capacity, inconsistent access to pathology, immunohistochemistry. Surgery without pathology is a compromised care, and limited advanced imaging. The equipment, downtime, and supply has a source age. Technology, different outcomes with some training teams, and even availability of radiotherapy. Resource management and financing. The common in this country is a underfunded public health system with high out-of-pocket costs for patients, lack of cost-effectiveness framework. The cancer surgery often viewed as high cost rather than high value. Patients delay or abandon treatment due to the cost, and competition priorities within Ministry of Health. Multidisciplinary care challenge. We have a limited access to formal tumor boards. The multidisciplinary tumor boards can improve outcomes, but routine is not common in this country. We have opportunity with virtual tumor board. The care power pathways is fragmented. It's a weak integration of oncology disciplines, and the coordination often depends on individual effort. Opportunity and regional strengths. A strong commitment from clinicians, growing regional collaboration in telemedicine and virtual education, the innovation often born from scarcity. Digital solution can live from infrastructure gaps, and task sharing and regional center of excellence, opportunities and the role of global societies, regional center of excellence and task sharing. The guidelines must be adapted to resource levels, advocacy for surgical oncology inclusion in cancer plans, organizations like World Society of Surgical Oncology can be catalyst. We have to improve or to develop a global partnership through the World Society of Surgical Oncology and build system not just skilled. Central America and Caribbean regional snapshot, rising cancer incidence across all countries, market disparate in surgical and radiotherapy capacity, specialized service concentrate in few urban centers. Key take-homes message. Access to surgical oncology is a global equity issue. Resource management is important as technology. System-based and collaborative solutions are essential. This is the reference. Thank you. If you have any question or comments, are welcome.
Good morning. My name is Mariano Jimenez, and it's a great pleasure to make this short presentation to the World Society of Surgical Oncology. My disclosure is more than 5 billion of persons around the world has without access to safe surgery. 80% of cancer patients need surgery, but unfortunately, less than 25% receive safe and timely cancer surgery. The gap is not technological, it's not primarily technological. It's about the system, financing, and the capacity. The situation in South America has 3 bottlenecks. First, is the territorial inequity. In urban center, in the majority of them, we have high complexity cancer care. Unfortunately, in the rural and peripheral areas, is less technology, less possibilities, less facilities, and the referral treatment pathways is super complicated sometimes. Persists inequities is not only in South America, in all Latin America and the Caribbean, is a social determinant and limited referral capacity. The second one is a shortage and maldistribution of the surgical workforce, and not only surgical oncologists, because the cancer surgery depends on a full care ecosystem, anesthesia, intensive unit, pathology, imaging, perioperative nursing, rehabilitation. Failure at any point compromise timelines and quality across the entire pathway. And this is important because sometimes the huge limitation is the pathology and the time of the pathology and the images and the time of images. And the last problem is the underfunding and incomplete prioritization of surgery in cancer control. Surgery is one of the core pillars of cancer control. The Lancet Oncology estimates 45 million cancer-related procedures annually by 2030. But without the increase the resources and increase the possibilities in the public system, the waiting list, the delayed referrals, and loss of curability will increase and not decrease in the next years. But it's not only the talk about the problems. It's my short talk is about the some possibilities proposal from in change our mind to from more resources alone to measurable access. For that reason, here we have a very short 6 actionable proposal. The first one is the oncology pathway governance, a standardized pathway, suspicion, diagnosis, staging, and surgery. Of course, the legislation is important, is the first step, but it's necessary more than this. In several countries in South America, we have law to say it's this time to the diagnosis to surgery in oncology will be not more than 60 days. But in reality, it's 90, 120 days or more. For that reason, the legislation is important, but it's necessary more than this. The target timelines to the biopsy and pathology report is necessary to define days and oncologic prioritization about these studies. And it's necessary to audit it, the confirmed diagnosis to first treatment to make really 30 and 60 days and not more. Of course, is the public dashboards by networks, by hospital is important. It's very common in the United States and very uncommon in South America and Latin America. But remember, the transparency drive improvement. For that reason, in case every hospital has the possibility to show the reality of the times and the results in surgical oncology is mandatory. The another 5 proposal is make decentralization is important, but it's necessary to reduce the inefficient decentralization. For that reason, the network model to have and spoke about the huge center with technological center and with the super experience center, but small centers around the country and around the population about the small places to make images, pathologies, etc. The third is the strength pathology and imaging bottleneck. Is for that reason it's necessary to make to send sometimes the pathology to some centers to make the telepathology in case it's not the pathologists in the little town, etc., with the idea to reduce the failure and reduce the time in this. This is more important than the time. We lost more time in pathology, more in the surgical waiting list. And the workforce planning and rotation with a team-based approach is necessary to make not only the number of surgical oncologists, it's the distribution of surgical oncologists in one country. The number 5 is smart financing, protect access and reduce out-of-pocket costs. Of course, the resources always is inefficient, is small in Latin America and South America, but is more resources without a strategy is not useful. And finally, the technological phase, value-based adoption aligned with capacity. Of course, the technology is essential, robotic images, artificial intelligence in navigation system, of course, is part of my work at this moment, but it's necessary to make a smart position of the technology in a smart in specific places. It's not the pen of is my friend, is the friend of the Minister of Health, or is because it's the classic hospital. No. In which hospital, which technology? The smart financial is necessary and is part of the future of our region in surgical oncology. And my last slide is necessary to control the results, to measuring equity in surgical oncology in South America. It's not only resources, it's necessary to comprove in which center, which money, in which province, in which state, in which city. The sentences is the right patient in the right place at the right time, without financial ruin for the family, of course, and for the country. For a possible, easy core indicator of quality and the good use of resources is the diagnosis treatment time, the pathology turnaround time, the case discusses in multidisciplinary team meetings in percentage, and risk-adjusted perioperative morbidity and mortality in our surgical oncological center. Well, thank you very much. I hope my lecture was around 8 minutes. Thank you.
Hello everyone, I'm Ailton Sepúlveda. I'm liver transplant and HPB surgeon working currently in Auckland City Hospital in New Zealand. It's a pleasure to be here with you, and thank you for the organizers for the kind invitation. Just to give you my background, I'm Brazilian. I was trained in Brazil and I worked in France for 16 years, and I'm working in New Zealand for the last year, so I'm facing a new reality. I'm more than happy to share my experience with you. So the theme of my talk is from Australia, and I included New Zealand, to the Pacific Islands, overcoming distance and scarcity in oceanic surgical oncology. Just to give you some geopolitical and historical aspects of my region. So it encompasses 22 countries and territories. The population is about 41 million inhabitants, and the land mass, all its population in a land mass of only 8 million kilometers square, in an area of 161 million kilometers of land and ocean. So that's why we call the blue continent, and that's why distances between countries are so significant. Interestingly, most of this population lives in New Zealand and Australia, and it's going to have impact in some aspect that we're going to discuss throughout my presentation. Social demographic disparities are common result of this, and we can see that in Australia and New Zealand the health indicators are much better than other countries like Papua New Guinea and Solomon Islands, with life expectancy of only 65 years and really high infant mortality. So we have two different realities, but that are quite intricate. And so on one hand, we have New Zealand and Australia with well-developed public and private health, with health indicators close to developed Western countries, and on the other hand, Pacific Islands with limited resource, shortage workforce, isolation, climate vulnerability, increasing cancer burden. And you're gonna see that we can also see this reality inside New Zealand and Australia, that has part of the population corresponding to indigenous and Pacific Islanders with low income, and that face inequity, isolation, and poor health literacy as well. Just to give an idea, there are more Cook Islanders living in New Zealand than in Cook Island, and it's the same for doctors and nurses. So there are more doctors and nurses from small islands living in Australia and New Zealand than in their hometown. Looking inside New Zealand and Australia, we can also see that distances are quite significant. And in this slide, we can see that there are not too many metropolitan centers in Australia and New Zealand, a little bit more in Australia in the eastern coast, and in New Zealand we have about 3 or 4 that make the distance from those centers quite important, around 2 to 6 hours. How we face that, how we cope with this. In New Zealand we have the National Travel Assistance that cover travel costs, not only for cancer, of course, but all kind of medical treatment, and they also cover accommodation costs for family. In Pacific Island, how they cope with this reality: over 30% of local health budget is spent on overseas medical referrals. So when they don't have the resource to give health care, they send to other countries, and can be Australia or New Zealand, but can also be France, United States, India, or China, for example. There are lots of partnerships right now. And to give you an idea about the economical burden of this health limitation in these countries, in microstates, they spend on average 14.5% of the GDP on health. Pacific Island countries invest only $500 American or less per capita year on health, while global average is more than 1,000. And of course, most of this expenditure is paid by domestic government, and you're gonna see that there are also some external help from other countries. Take an example of the breast cancer and and the delay on presentation to medical care in Fiji. This recent study shows that some reasons for that are fear, lack of knowledge, healthcare system delay, preference for alternative treatment, financial and transport difficulties, and lack of family support. And bringing this to my reality, this is exactly what the difficulties that I have with some indigenous and Pacific Islanders living in New Zealand. So we have this reality also inside our country. So it has a lot to do with health literacy, and according to the World Health Organization, health literacy is the cognitive and social skills which determine the motivation and ability of individuals to gain access to, understand, and use information in ways which promote and maintain good health. And I think that explains a lot why we have so high mortality in some cancers. Take an example of the hepatocellular carcinoma, which is closely related to hepatitis B. We know that Pacific Islanders has low access to vaccination and information as well, and as a consequence, we have a really high mortality. So Oceania has less than 1% size of Asia and has highest mortality from HCC comparing to other countries. And we can see that it's also related to the lack of screening. So we know that when we can screen and identify those cancer earlier, we can be more curative. So there are several international aid programs to help coping with these difficulties, these issues. From the Royal Australian College, they provide technological educational support aimed to strengthen regional health system and improve local workforce. Other non-governmental initiatives like Rocket Ship from Australia as well. And from the New Zealand side, we have the New Zealand Medical Treatment Scheme, not only for cancer, but all life-saving medical treatment that can be offered to Pacific countries. It's been for over 30 years and include 6 Pacific islands, providing overseas referral scheme and visiting medical specialists. So there's still several challenges. I'd like to know some of them. First one would be improve local health literacy. Second, develop local and regional cancer registries. And third, providing broad accessibility to screening and follow-up programs. And ultimately, we would be able to provide access to advanced surgery and as well as neoadjuvant and adjuvant treatments. So thank you very much for your attention, and I'm more than happy to discuss with my colleagues around those themes. Thank you.
Good afternoon, everyone. Thank you for the invitation. Today, I will be presenting on Europe's critical role in overcoming political and regulatory barriers in surgical oncology. This is a strategic overview of how Europe is leading the way in creating collaborative framework in cancer treatment globally. Let me begin by framing the challenge we face. Cancer remains a global health crisis. What is particularly important here? As you know, surgical oncology is critical for approximately 70% of all cancer patients. Yet, barriers prevent optimal care delivery and innovation across borders. So, what are these barriers? First, let's look at political challenges. We have healthcare fragmentation, difficulties in resource allocation, and finally, geopolitical tension. Beyond political issues, we face significant regulatory barriers, such as inconsistent standards. That means divergent approval process for surgical oncology training, surgical techniques, and device. And this creates inequities, delay, and increased cost for innovation adoption. We have also credentialing complexity, data protection conflicts, and reimbursement disparities. Now, why is Europe positioned to lead in overcoming this barrier? Europe has several strategic advantages. First, we have several pan-European networks like ESSO and URTC provide proven frameworks for collaboration. Second, Europe has harmonization experience. And finally, we have research excellency. Europe leading cancer centers are driving innovation in minimal invasive and precision oncology. Europe leadership is demonstrated through several key initiatives. Number 1, Europe Beating Cancer Plan. This is a €4 billion initiative that addresses everything from prevention through survivorship with a particular focus on surgical access equality. 2, European Reference Network. 3, the Joint Clinical Trial Regulation. And 4, ISO certification program provides standardized surgical oncology training and accreditation across more than 50 countries worldwide. Let me give you a concrete example of success. Look at what happened with clinical trial harmonization. The impact has been remarkable. European surgical oncology trials have increased by 14% since 2019, and we are now establishing global gold standard for evidence generation. Do Europe regulatory frameworks influence worldwide? Yes, Europe influence extend far beyond our borders. For example, Japan, South Korea, and Australia are adopting European Community Medical Device Regulation and surgical training standard. ESSO collaboration with the Surgical Society in Brazil, Argentina, and Chile, strengthening regional capacity. European training program and telemedicine platform expanding surgical oncology access in sub-Saharan Africa. We have also collaboration with WHO organization. Looking the three major opportunity for expanding our impact. First, digital health integration. We need unified electronic health records, a high-power surgical planning, and cross-border telemedicine capability. Second, precision oncology standard. Developing genomic profiling protocols, personalized surgical approaches, and biomarker-driven decision-making frameworks. And finally, global registry development, creating standardized outcome metrics, real-world evidence collection system, and quality benchmarking tools that can be used worldwide. What is our strategic recommendation? First, expand European collaboration with WHO, UICC, and regional societies. Develop mutual recognition agreements for surgical oncology credential globally. Build interoperable platforms for data sharing and virtual tumor boards. Create sustainable fellowship programs and technology transfer initiatives. And finally, advocate for right to treatment and cross-border care access worldwide. In conclusion, Europe has demonstrated a capacity to overcome political and regulatory barriers in surgical oncology through collaborative frameworks that transcend national interest, evidence-based regulatory harmonization, and sustained investment in research infrastructure and training. By continuing to lead in standard development and knowledge transfer, Europe can shape global surgical oncology to deliver equitable, high-quality cancer care worldwide. Thank you.
Rodrigo, Domênico, Timothy, Felipe.
Hello, hello.
Fechou.
Yes, I'm online.
Hello, everyone. Hello,
Yes.
everyone. Moving forward to our panel discussion, I'd like to thank to all speakers, outstanding lectures, outstanding speeches, and we learn a lot with them. And I'd like to invite Dr. Domenico Dugo from Italy, Dr. Felipe Coimbra from Brazil, and Dr. Timothy Pollack from the United States to share some insights, to share some some comments and questions with us. Thank you.
Thank you, Rodrigo. Am I online? Do you hear me?
Yeah.
Yeah.
We have Professor Domenico and other speakers. We have 16 minutes to debate.
Thank you. No, just a brief comment, because we have, if there was any more evidence, we have the witnessing of the fact that inequity is worldwide. It's not just a limitation of resources in lower economy countries, but inequity is something that we should fight in different geopolitical situation and socio-economical situation. There are so many questions that have been, exploited during this incredible presentation that were extremely clear. But I would focus on the fact that we are a federation of society of surgical oncologists. So, of course, prevention is the key for reducing the incidence of new cancer, treating them at the beginning. We have seen today in the World Cancer Day that 75% of cancer can be just cured by surgery if taken at the early phase of their development. But our main focus should be another one. Being early cancer or being an advanced cancer, every citizen of the world should have the right of being operated by a surgeon who is a certified, qualified surgical oncologist. As Professor Veronesi said, a surgical oncologist is an interventional biologist. Is somebody who is not technically operating on an organ, but who can imagine the consequences of these technical maneuvers on the possibility of survival of the patient. So the first step for surgical oncology is certification, and possibly worldwide certification. Then resources. Of course, resources can never be the same at the present, especially in this world economical and geopolitical situation, but AI is changing this perspective. The possibility of communicating, developing mentorship programs, and maybe very soon operating by far is something that is changing this landscape. So introducing technology in terms of resources by far can be another important topic for the next future. The third one is networking, establishing guidelines, confronting with benchmarks, renewing the individual standards in order to have always some new goal to establish is just obtainable by networking altogether. So these are, for me, the three main mission topics of a system for a World Federation of Surgical Oncology. Certification of quality, development of ideas and plan, even adopting new technology in order to apply the same kind of quality techniques worldwide, even at far long distances. And the third one is networking. Networking for quality, guidelines, and new goals. Thank you very much.
Thank you, Professor Domenico. It was a pleasure to have you here. Professor Timothy, are you here? So let's, Professor Philippe.
Yes, thank you. Really great lectures, really great panel from all the regions over the world. And this was really impressive to see actually how many common points we have in disparities too, right? And so I believe really, in the words, I'd like to make some remarks over all the talks we've seen today. So access over tumor biology. So that's something to start discussing in our main congresses all over the world. So this is very important, I think. So I thank you for this statement from Newton, and I think this resumes a lot of things. Unequal distribution of surgeons and teams, not only the surgeon, but all the teams that work together with surgeons. So this is very important also to start. Like also to highlight a very important gap, and also in a way to make it even over many countries and regions. So training and education gaps. So this is very important. And I would also say access to sometimes so tumor boards.
Perfetto.
There is also the systemic barriers to care, such as insurance coverage gaps, geographic barriers, delayed referrals are very important. So when to refer to the specialist in cancer surgery. So this is very important. So a very important, a good point to discuss. And of course, as we are discussing here in WSSO and people from all over the world, global collaboration and discuss solutions to this. So we believe we have many possible solutions, not unique, many different ones that can be adapted to different regions. So develop global standards with minimal standards for the main important kinds of surgeries. So this is very important to and also to have a timely access to cancer surgery, education, mentorship. That's something for sure we are going to foster for this. Support regional surgical oncology networks and global oncology networks, and also highlight the importance of surgeon as a bridge from the early diagnostics to the curative treatment. Because if these patients have early diagnosis, that's something that we all would like to go for and insist with governments and all the countries. The next step is surgery, because it's this main curative treatment for all these patients. So with this, I'd like to thank you again. We have a very short time for discussion, but these are the points I'd like to highlight, and for sure WSSO will foster these main important points here discussed. Thank you.
Thank you, Philip. Dr. Tim, are you with us? We have some connection problems right now, but so I'd like to open the speech for some of our speakers. We want to share something or take more insights or share more insights. We have some minutes, a couple of minutes.
Yeah, can I speak something?
Yeah, Dr. Chandra Mohan from India. Welcome.
It was a very good attempt indeed to start with this webinar. And it has actually enlightened me a lot. Like the many regions of the world share the same problem. And at the same time, if you look at the European presentations, has shown us, their contribution in terms of the evidence-based medicine by EORTC, etc. At the same time, even in developed countries, there is inequitable distribution of resources because of money, distance, etc. But I think this forum can contribute in a significant way. Last 3 decades or so, I am seeing that Indian oncology contingent is gaining strength. And to begin with, all of us 3 decades back went to Europe or US to get trained in oncology. But now I think we are self-sufficient and we are attracting some youngsters from even other countries. And if you look at the globe at large, you can see various expertise at various places. For example, the non-operative management of rectal cancers has started in Brazil. And likewise, this forum, if they can throw across the opportunities across the globe, irrespective of the country, either online or offline direct visits by networking, we can make use of it. And wherever you are born or growing, it's very important that you have to learn these things from international community. And I hope that WSSO can be a networking place where everybody can come and share this expertise. And moreover, I think another attractive thing, I think that we can have international tumor boards. We can have multidisciplinary tumor board because even in India, there are certain places where there is no access to MDTs. So if you can maybe run it on a free basis or some cost basis, I think that is going to definitely work out. And I see a lot of potential for this gathering here, and I hope that we can make significant change in the world of surgical oncology. Thank you very much.
Thank you. Dr. Ailton, some final words.
Thank you, Rodrigo. Yes, it was really such an opportunity to realize those different situations, different social, political realities with the same problems. And in one hand, we have the bright side that probably we're gonna find solution for these problems in different countries. And actually, we have some good insights from India. We can probably develop some local solutions for early diagnosis and screening. And MDT is something that we can work as well, and going to have a positive impact for sure. So yeah, I think we have a lot of work to do. And I think the society is well placed to address all these problems, and I'm pretty sure we're gonna have a good achievements in the near future.
Thank you so much, Dr. Ailton. Dr. Newton, are you here? Dr. Sergio?
Rodrigo, while we wait for the others, there is a red line that has joined all together these presentations and comments. That is the need of establishing a common quality plan of treatment, more than maybe a technical plan of treatment. And why do you think, if the next step for this federation could be offering worldwide, international, local, regional, multidisciplinary tumor boards for difficult cases to be discussed with the presenter of the case all over the world. These doctors will be not only strongly supported by a quality plan of treatment, but will learn how these cases should be worked up and understood. So this is a common, step forward for the society, the participants, and the patient. I think the first thing that it's very easy to be done is identifying regional responsible who, as first step, are joining people together, offering them the possibility of having maybe once a month a multidisciplinary specialized online tumor board for very peculiar cases. This is a very easy proposal and can be a very good first step.
Yeah, great idea. And so we have a few minutes more in moving for the closure. Seems to be our call to action is pretty clear right now. Achieving equity in surgical oncology will require a unified global approach grounded in collaboration. No region can solve these challenges alone, but together we can align efforts, share solutions, and amplify impact. The final words to the closure for this webinar, I invite Professor Domenico and Professor Alexandre Ferreira.
I'd like to congratulate everyone on the organization of this first WSSO webinar. I'd like to extend my special thanks for the directors and the members of the scientific committee who contributed to its realization. The theme of this webinar highlights that although some challenges are region specific, many others are shared, regardless of the region of the world. I am confident that the very creation of the WSSO is alright, justified by the opportunity to exchange successful experience among countries, along effective solutions in one context to benefit others. The standardization of practice while respecting the technological resources available in each region has the potential to minimize this challenge and reduce cancer-specific mortality. Congratulations to everyone on the excellent work. And I invite everyone to next webinar, March 12, 2026 at 12 p.m. Brasilia time for one the team from the early detection to curative therapy, the social breeding cancer care pathways. I now give the floor for the closing remarks to our President-elect for the 2026-2027, Dr. Domenico Dugo. Thank you.
Dear friends, it's me to be thankful, not only for being called and elected to such a prestigious, important, and heavy topic. I mean, I was so enthusiastic of seeing this incredible participation from all over the world. Every country of the world has been represented very clearly by incredible experts. The objectives of being here together now are very clear. Our goal, our mission has been strongly established. Now it's time to move on. It's time to establish new standards, new goals that can be respected worldwide and move together, since the interest, the participation, and the passion that I see in a webinar like this is incredibly high. Thank you to everybody, and join WSSO. Tell your friend to take a look at our website, and don't forget to stay online. Next webinar is fixed to March the 12th next month. Thank you very much again.
Thank you.
I ask our speaker to turn on the camera of Arafat.
Thank you.
Okay?
Yes.
Thank you.
Yeah.
Thank you.
Thank you.
Bye.
Bye-bye.
Bye.
Thank you, guys. Thank you. Thank you all.